Welcome to Anorectal Mastery, a clinical and board review for GI residents. This video incorporates updated 2024 guidelines from ASCRS and ACG. Our learning objectives cover three key areas: foundations, diagnostics, and management. We will master anatomy, identify features of specific conditions, and implement triage strategies. We begin with the foundation, the essential anatomy and physiology knowledge for the gastroenterologist. The pelvic floor unit includes the puborectalis muscle, sphincter complex, and the dentate line. Remember, the puborectalis must relax during defecation to straighten the anorectal angle. Defecation mechanics involve RAIR, the sampling reflex, and the strain phase. A key tip is that postural squatting with a footstool significantly improves the anorectal angle, reducing straining force. Part 1 focuses on rectal prolapse, covering everything from occult intussusception to external procedentia. Rectal prolapse is classified as full thickness or procedentia, partial or mucosal, and internal or occult. Full thickness shows concentric mucosal rings. Internal is diagnosed via MR defecography. The concentric sign distinguishes full thickness prolapse with its concentric rings from mucosal prolapse or hemorrhoids with radial folds. If a patient complains of a bulge but you see nothing, consider internal prolapse and perform a dynamic exam. The sit and strain assessment is crucial. Commode examination helps detect elusive prolapse, and a digital rectal exam must assess both resting and squeeze tone. Sudden pain with irreducible prolapse is a red flag requiring emergency surgical consult. Full-thickness procedentia is pathognomonic for concentric circular folds. A sudden pain plus dusky color indicates an incarcerated prolapse requiring emergency surgery. A tip is to use granulated sugar to reduce edema in an acute prolapse. Mr. Defecography is essential for diagnosing internal intussusception, allowing dynamic visualization of evacuation, quantifying perineal descent, and identifying multi-compartment defects. Surgical decisions depend on the patient profile. Abdominal approaches are favored for fit and young patients for lower recurrence. Perineal approaches, like Altemeyer or Delorme, are for frail and elderly patients, avoiding general anesthesia but with higher recurrence. We now move to Part 2, solitary rectal ulcer syndrome, often considered a great misnomer. SRUS is not always solitary, with 30% of patients having multiple lesions. It's not always an ulcer, sometimes presenting as hyperemic patches or nodular masses. The classic location is the anterior rectal wall, 4 to 10 centimeters from the anal verge. The pathogenesis model involves mechanical force, specifically chronic paradoxical puborectalis contraction. This leads to toe fibromuscular obliteration, the histologic hallmark of repetitive trauma and ischemia. The mechanical crush involves dysenergic defecation, which creates a physical barrier. This leads to mechanical trauma, forcing the rectal mucosa against the contracted muscle, and resulting in ischemic injury. The ulcerative form presents as a shallow, well-demarcated ulcer with a gray-white base. Importantly, the endoscopic appearance can mimic adenocarcinoma or Crohn's proctitis, making a biopsy mandatory for definitive diagnosis. Histologically, the diagnostic anchor is fibromuscular obliteration. This includes their replacement of the lamina propria by smooth muscle and fibroblasts, and crypt distortion, which rules out inflammatory bowel disease. Biofeedback is the most powerful first-line therapy, boasting a 67% success rate. It retrains the puborectalis to relax during evacuation, leading to complete clinical and endoscopic healing in 2/3 of patients. The SRUS management staircase begins conservatively with high fiber and laxatives, followed by biofeedback. Topical treatments like sucralfate enemas offer symptomatic relief. Surgical rectopexy is reserved for cases with refractory full-thickness prolapse. We transition to Part 3, anal stenosis, examining the causes and cures for this iatrogenic bottleneck. The etiology is predominantly iatrogenic post-surgical, accounting for 90% of cases, often following excisional hemorrhoidectomy. Other causes include radiation proctitis and chronic anal fissures. Rapid progression requires investigation for malignancy. Anal stenosis is graded using the Milsom scale, which correlates the severity of the narrowing with the diameter of the dilator that can pass. Intervention starts with concentric radial expanding balloon dilation, using incremental pressure and size. Begin at 12 to 15 millimeters and advance to 18 to 20 millimeters, minimizing fissure risk in the first session. For severe stenosis, the VY advancement flap is the preferred reconstruction technique to restore pliable skin. It moves healthy perianal skin into the anal canal. Crucially, never dilate active Crohn's disease. We will now apply this knowledge with 3 case vignettes to test your mastery of these concepts. Case 1. A 28-year-old male with rectal bleeding and mucus presents with a friable ulcer. The question is, which histological finding definitively points to solitary rectal ulcer syndrome over inflammatory bowel disease? The answer is B. fibromuscular obliteration, which is the pathognomonic finding from mucosal prolapse syndrome, and SRUS. Case 2. A 72-year-old female reports chronic fecal leakage and a mass that protrudes only after straining, despite a normal bedside exam. What is the most appropriate next diagnostic step to identify the occult condition? The correct answer is Mr. Defecography. This dynamic MRI is necessary because bedside exams often miss internal intussusception. It allows visualization during straining and identifies multi-compartment defects. Case 3. A 62-year-old male with a short history of tenesmus, severe pain, and rapid pencil stools with no prior surgery. A rigid, stenotic anus is noted. What is the most immediate clinical priority to rule out a red flag diagnosis? The correct answer is fibromuscular obliteration. The rationale is that FMO is the histological anchor for SRUS and differentiates these polypoid lesions from adenocarcinoma or IBD. Case 4. A 45-year-old female presents with pencil stools 1 year after a hemorrhoidectomy. Her anal canal is severely tight, resisting even an index finger. What is the definitive surgical management for this severe iatrogenic stricture? The correct answer is VY advancement flap anoplasty. Severe stenosis, or grade 3, requires flap reconstruction to introduce pliable healthy skin into the canal, as dilation often fails in rigid scars. Case 5. An 85-year-old male with a known prolapse presents with severe pain and a 10 cm dark purple, irreducible protrusion. What is the most immediate clinical priority? The correct answer is emergency perineal proctosigmoidectomy, also known as Altemeyer. An incarcerated irreducible prolapse with ischemia is a surgical emergency, and the perineal resection is safer for this high-risk scenario. Here are some crucial red flags. Rapid stenosis in a virgin anus is malignancy until proven otherwise. Duskiness and severe pain in rectal prolapse indicates ischemic necrosis risk. Finally, digital extraction maneuvers correlate strongly with SRUS.